when we say DBS programming, what do we mean, and why is it essential after surgery? Why isn't it just you put the equipment in and it goes? Can you just talk about what it is and why it's necessary?
What we place in the brain is leads, one on each side of the brain, and then that lead is connected to a battery or pulse generator. And with that, we create a field. So when you come back for programming after surgery, which usually starts at least 2 weeks after the surgery is complete, now the neurologist, using different technologies that is available to us, will create a field that will kind of modify the disruption in the circuits that is causing the symptoms. So in the brain, the movements are not really coming just from one location, one nuclei. Instead, it's coming from kind of a nice balance of organized outputs from different targets and talking of different nuclei with each other. And there's disruption in this in Parkinson's disease. And what we do with creating this field is that we create a field that will disrupt that disruption and bring the organized orchestra of communication between these nuclei. So that's why we need to program. And with programming, we are targeting the symptoms that the patients are bothered by, and based on the programming, we try to improve them.
So when you say field, you're talking about the electrical field, right? So the brain's communication is all electrical. So the deep brain stimulation device sends signals by a field of electricity that is adjustable.
Correct.
And that helps to restore order in some way. Is that a fair summary?
Absolutely. You said it right. Exactly. That's the purpose.
Okay. So there's a couple variables here, right? And one of them is where the therapy is delivered. Mm-hmm. And so can you talk about that a little bit? How do you know that the field or the therapy is being delivered to the right place?
That's such a good question. Real estate. Where do we want to stimulate is the question. So that's the decision that is made before the surgery. That's the decision that one person usually doesn't make it. A team makes it. That's the benefit of having a multidisciplinary group that looks at all the symptoms of the patient, not just one. So if you come to me and say, I have tremor and I put you through surgery tomorrow, I may pick 3 different targets because all 3 different targets could potentially improve the tremor. But what is important is what else is defining your quality of life? What else is causing problems? Beside the tremor, do you also have a little bit of extra movements, what we call dyskinesia? Do you also have a little bit of posturing or painful cramps or things that are waking you up in the middle of the night? We call dystonia. Do you have toe curling? All these other symptoms. Do you have dystonia? Do you have dyskinesia? Do you have tremor? How's your balance? Are you falling? Do you have freezing? How's your speech? Do you already have a lot of speech problems? Is the speech important in your job? All of these questions are answered by a group of people who will evaluate the patients. Together, we all will decide, okay, this person is a candidate for surgery because he can tolerate the surgery. She can have good support after surgery. She will come to programming. And then we'll say, okay, based on their goal for surgery and based on the limitations that were presented by different number of these groups, what are the best targets? What's the best target that we can go for? And we'll say, okay, this is the best target. And then we'll ask our surgeon, we'll say, we want this target and we want this platform for this person. And so by the time the patient comes back to me for programming, I already have decided that this is the target of a stimulation for this patient that I want. And then target, the lead is placed in that target and I'm just going to program it.
Okay, so there's a lot of factors that go into which site you choose to put to direct the stimulation towards. Exactly. And it sounds like the leads also have some ways that they can be sort of controlled or manipulated where that field is generated around those leads. And we'll talk about that in a little bit. That's true, right? That those leads will have a factor in what the program. That's actually what you're doing. Is that true?
Yes. So the leads are very advanced these days. So the initial leads that we had were kind of like very basic, and you could just make one type of a stimulation. The leads that we have these days, they have the capacity to steer the field of a stimulation in a certain direction. So instead of just creating a big field in the brain that could potentially cause side effects in the neighbors of our target, now we can steer the field in a way that will give us benefit, but will not result in side effects such as pulling, numbness, paresthesias, numbness, symptoms that patients can be bothered by, or speech problems.
Okay, so I think maybe I want to ask you a quick question to follow up before we jump into more. I have questions about the adjustability, but before we get there, I want to ask if you can say, I go through the procedures or the interviews with my neurologist, and then the team gets together and they talk about the decisions made. I have the surgery, and then I come to you for programming. Say, how do I prepare for that first visit? What do I need to know about coming to see you when I come to see you for programming?
Before I get there, I want to pause and say one other thing. Your neurologist, your movement disorder specialist who decides when it's time for you to go for evaluation for DBS is very much involved in the target selection and candidacy selection. So it's not like the DBS team is a separate team and now you're introduced into a new world. This day, a lot of the most movement disorder neurologists and most neurologists are familiar with programming too. So often even patients go back to their movement disorder specialist for programming. If we have patients who their neurologist is not comfortable with doing the initial programmings, we do the initial programmings too, and then we will send them back to their neurologist. But you are not building new relationships here. This is someone that you have met before surgery, and now you're meeting again after surgery for programming, if they're not your movement disorder specialist.
Right.
For patients with Parkinson's disease, we ask the patients to come in an off state, meaning you do not take your levodopa or Parkinsonian medications from the night before programming, and then for 12 hours you'll be off, and then you come in. This is a little uncomfortable, but the reason why we do this is that we want to see the worst of the symptoms and try to manage them best that we can with programming, and then add the medication. We ask the patients to bring their medications with them. So after we're done with programming, then they will take their dose of medication, and then we'll watch them to see if the addition of medications to the programming will not cause too much movements or dyskinesia. And then we'll make adjustments before they go home. But usually I ask the patients to bring a family member with them. This is a moment that they've been waiting for several months, and it's good to have a family member that they feel supported by. This is the first programming session is usually a little longer. We spend time teaching the patient programmer and how you can navigate with that.
You just to be clear, you mean the device that I would have, that I can make changes, small changes maybe, or the things that I have in my control. That when you say patient programmer, that's what you're referring to.
Exactly.
Okay,
yes.
great.
So we have a programmer that is clinician programmer, and we program you with that. But then during the visit, what we will do is that we will define what is that safe window that you can go home and make adjustments during that window. A window that will not cause any side effects for you, and a window that will not give you any uncomfortable side effects. And if you have a day that your tremor is worse, you can click up by a click to see if your tremor will be better controlled. A day that you're feeling a little slower, you can click up. Or if you feel that today's is a day that actually I'm having a little more dyskinesia, extra movements, you can click it down a little bit. So There are instructions, detailed explanations of when to increase your stimulation, when to decrease it, how to make adjustments. We will give it all in written instructions to you, and we'll give you like booklets of how to use with your patient programmer, the one that you will have at home. And all of that will take a little time. And then also after surgery, sometimes people have some other non-motor symptoms that we want to talk about. We don't want to just focus on programming. We want to ask them about their sleep. We want to ask them about constipation right after surgery. You were taking pain medications. How are these symptoms controlled? We want to make sure that we control all the symptoms that are bothersome for the patient. So that's a little longer a visit. So we ask patients to be ready for that. Perhaps bring some snacks, bring a family member, bring your medications with you. The second visit, the doctor will tell you whether you need to come in an on or off state. If your symptoms are very well controlled and you're doing really well, you may just come in an on state. So we see an extended on and make some minor adjustments, some programming. And then there's usually a third programming a month after. So the second programming is a month after the first, and the third is a month after second. And we make minor adjustments to make sure the final program is working really well for the patients. And they have the windows of change if they need to.
So just to summarize, I guess it sounds like one should be prepared for maybe not having a comprehensively effective, it may not be the best possible treatment effect after your first visit. Sometimes maybe, but maybe not.
Correct. Sometimes, especially for some symptoms such as tremor, it may take at least 4 months for the symptoms to improve. And we are gradually making changes in programming and adjusting the medications. So it's not like a button that will turn things on and symptoms will go away. It's a bit of work to find out with each programming that we do, what are your benefits, what are the limits, what are the modifications that we need to make. And throughout all of this time, physical therapy rehab is very important to make sure that you just went through a surgery and you're going through modifications, going through medication adjustments. You make sure that you're constantly working on rehabilitation as well.
Okay, so this is a little bit of a this isn't like a one and done type of situation, in part because Parkinson's will change also. So over time, I'll have more visits, and the parameters of the settings the settings you make will change over time as Parkinson's changes, right?
Correct. So we can make changes over time, and that's something that we will always do in your follow-up appointments. Something that you will come and say, I only had tremor in my right hand. Now I have tremor in the left hand. Do I need any adjustments? Of course, now we are going to focus more on the left side, and we are going to improve things. Or patients will come back and say, oh, over time, over years, I have developed this and that side effect. And we will go back to the programming and see if the programming is causing this side effect, or is it the progression of the disease? That's always something that we ask ourselves. Is it a side effect of programming, or is it progression? The first 3 programmings are the most comprehensive programmings anyone will have. But then we will probably by then have gotten to the sweet spot. We've probably gotten to where we need to be. From there on, programmings are troubleshooting and are not going to be like as lengthy unless someone has just very unilateral symptoms at the beginning that we didn't even program the other side. In that case, it will be a comprehensive contralateral programming for that person.
Okay. Well, thanks for that. I hadn't considered that you might not do anything to a side that was not very affected initially. That's interesting. So maybe can you tell me a little bit about when you are making these programming adjustments? What are is there anything I should know as a person with Parkinson's about the settings you are adjusting in that? Is that relevant to me? What does these settings do? Can you talk a little about what your power is?
Yeah. So this will be a little going into detail. So what are the things that we clinicians look at when we're programming? we look at three measures that we have. It's the number of stimulation per minute frequency. Then we have the pulse width or duration of a stimulation. And then we have the amplitude or strength of the stimulation. What we usually give you limits to go home and make adjustments at home is the amplitude. So the amplitude is the strength of that program that has been created. So when I see you for programming, I create a shape, and I know that my shape, if it gets a little bigger, will not cause any side effects, will not stimulate the neighbors that will cause like pulling or this or that as a side effect. I will give you those limits within that safe limit, and I let you make the field a little stronger or a little weaker if not needed. So amplitude is what you're playing with at home, or what is available to you for modifications.
So it sounds to me like you talked a little bit about the different types of leads, and now there's a lot of control that you have and a lot of the different features that the leads have. You alluded to that earlier, and it sounds like that's a very important development based on what you're saying now, because you can direct where the stimulation is going more precisely than you could before. Is that true?
Yes, yeah. So the directional leads were kind of like a breakthrough for us, that we now had a lot more capability in programming, and this has been available to us for at least, I would say, a decade now.
And does that help with anything in particular? I mean, you mentioned the pulling and that, but that sounds like it's amplitude as much as it is direction. But is there anything particular that the directional leads help with to help avoid side effects?
So yes, so direction. So think about the lead as the contacts on the lead. They can just be around the lead all over, or they can be in three different directions. I am able to now direct the field of stimulation more towards my target and away from the neighbor that causes that pulling. I'm not going to get into how I go away and steer it. Those are all details of programming that we teach our fellows, and how to do it, how to block it from not getting to where it shouldn't get. So this will make it very technical. So let's not get there. But
Sure.
With different techniques, I am able to steer towards the target and away from the side effects. But all of that is when my lead placement is ideal. So if my lead placement, so that's why we rely highly on our wonderful surgeons who are experienced in this procedure, that they know where the target should be. So if the lead is not well placed, unfortunately, even with a directional lead, I will not be able to manage the symptoms well as a programmer. That's a case where I will ask my surgeons to consider a revision, lead replacement. The lead should be well placed for me, and then I will use this added value of technology to really push the target to the sweet spot and make sure it doesn't create any problems that are unwanted.
So, we talked earlier about how do you know you're stimulating in the right location for a given person. Is there a way you know if the lead is in the right place? I mean, they must be doing scans or something. How do we know that the lead's in the right place?
So different platforms allow us different ways of measuring it. So, for example, image-guided programming is one way that Boston Scientific allows us to look at the CT scan and MRIs before, CT after and MRI before surgery, merge them together, see where the lead is, and program based on location of the lead. Medtronic, which is another platform, will give us the ability to sense. So basically, I am now looking for a signature of Parkinson's disease, and that signature frequency will tell me, this is the sweet spot. This is where I should be stimulating. And with that, I'll be able to say the location is in the ideal place.
Okay, so when you say sense, you mean that there's like a sensor on the lead that can give you information as you're looking at whatever device you use to program the stimulation settings?
Correct. So if the leads have the capability of sensing, on my clinician programmer, I am able to see or see the frequency of interest. So for patients with Parkinson's disease who have a slowness and stiffness, there is one signature that I can see based on sensing that this is the location I should be stimulating if I want to treat that symptom. The tremor has a different frequency of interest. So I will be able to tease out the frequency of interest based on a sensing lead information. So that's one way of finding out where the sweet spot is.
That's really cool that they're different frequencies. That's so interesting. But let's go a little bit more on the devices if we can. So you mentioned two, the Medtronic and the Boston Scientific. There's another manufacturer at Abbott, and they have another thing about programming. So can you talk just a little bit about the difference between Abbott programming and what they offer?
Yeah, so each of our platforms that are available to us, the three, have different options available to us. Abbott provides remote programming at this day, and we are able to remotely program patients who are not able to make it to the programming follow-up visits. And that's something to consider if the patients are really remote and they don't have access, they don't have the ability to kind of have transportation to the centers. Remote programming can make this deep brain stimulation available for these patients. So that's a unique feature that Abbott has. I should say that still for the first programming, we will ask even those remote patients to come to the office, because the first programming, it's very important to be done in person. For the minor adjustments, the follow-ups, it's okay to do it remotely. We could do that. But even for those patients that have access issues, we still want the first programming to be in person.
So there's you now talked about the three devices that are available in the U.S.
Right.
And I guess can you just give a quick summary of what the differences are between those three so we can restate those?
Yes. So we talked about Abbott, and then we have Medtronic. Medtronic has the capability of sensing, and people often hear about adaptive DBS. And adaptive DBS is a feature that Medtronic makes available. And what Medtronic has made available through sensing leads is that you will be able to create a program that will sense the signature for a given symptom and give the right amount of stimulation to the brain when that frequency is read by the lead. And then with the frequencies treated, then it will lower the amount of stimulation. So it's not always delivering a fixed amount of therapy stimulation to the brain, but instead it's reading the signature in the brain constantly. And when it's needed, it will give it a little more therapy. When it's not needed, or perhaps when the patient is asleep, it will give less amount of therapy. So it goes between up and down. There's another way of stimulating through adaptive is that the patients will get a burst of a stimulation when needed. And these are different ways of adaptive DBS. So if patients hear about adaptive, that's another new a feature that is available for our patients with Parkinson's disease. And Boston Scientific, like I said, provides the image-guided programming feature, which is very useful for us when we're programming. We are actually seeing the location, the anatomy of the patient, and based on the anatomy, we are able to stimulate the area of interest and try to avoid the side effects. So, for example, in the past, as we went through monopolar reviews, we would just go throughout the lead and say, oh, at this point, patients having such trouble with side effects. now I don't even have to put the patient through those side effects. I see that this location of the lead is going to cause pulling. So I'm not going to bother that patient. I will steer the stimulation a little differently so the patient doesn't even experience that trouble.
So you just described, like, I would be at such a hard place to try to decide which, like, I don't even know if I was going to have DBS. If I was consulted for this now, I don't know which one I would prefer. And that's, I think, why it's important to have people consult each other in terms of your care team, because it's just a very complicated, there's so many virtues to these different systems, right? Is that fair to say?
Options these days. Like I said, we talk about DBS, we talk about focused ultrasound, we talk about all these different platforms. And that's why it's important to kind of rely on a team to decide what's the best option for you. And each of these targets that are available, sometimes different platforms are more useful than the other. So we may sometimes say, based on the target that we have chosen for you, this is what we suggest that you choose. We don't ask the patients to decide. It's not like buying shoes. So also what do you want? It's like something that we will, at the end of the care conference, usually the neurologist will pick up the phone and call the patient back and say, okay, we discussed your case tonight. We discussed that you're a good candidate. We suggest this target and we suggest this platform for you. And in deciding this platform, we have consulted your movement disorder specialist if this is a referral coming from outside. Often we take into account that if a neurologist or a movement disorder specialist who is going to program this patient in future is more comfortable with the platform, then we are fine with making some modifications to that so the patients can continue with their neurologist and movement disorder specialist.
Great. So it sounds like maybe there's a factor that you hadn't mentioned yet, that you just mentioned, and let me see if I heard you right. There is some difference in sort of programming familiarity for the person who's the programmer needs to be aware of the features of the system, I guess, is what you're just saying, right?
Yeah.
So that's a factor.
Correct. That's a factor. We factor that in as well. If this is a remote patient who's going to be following with their local neurologist and their local neurologist is only familiar with this system, we factor that in making sure that the patient doesn't lose their access for programming. So these are all like high level discussions that we like factor them all in making a final decision of what's the right platform, what's the right target, what are the goals. Bottom line is improvement in quality of life. And in order to get to improvements in quality of life, we have to factor in what is important in life for each individual patient. Often we ask the patient, what are your hobbies? What do you like to do? Some patient likes to make model houses. So I know that this person needs perfect, precision in both hands. So tremor is their main goal. This is different than some other patient who says, my dyskinesia is really bothersome. I'm falling because of it. Mm-hmm. And where they come from, they all are factored in before we make the final decision.
Well, thank you so much for all the information you've shared. I've learned a lot from talking with you. And I maybe I want to ask one last question if I can.
Yeah, absolutely.
What signs do you think someone should watch out for that tells them you should really talk to your programmer because you might be in need of a programming adjustment? How does somebody know if that's the situation they're in?
So one of the most important things is if you had symptoms control and everything was going well and suddenly things aren't and something is different, that there are some factors that we have to look into. Is the device still working? Do you have did you have a fall and a fracture? Things that we should check. Impedances, resistance of the system is what we check to make sure everything in the system is working well. If you have like worsening of symptoms after the initial first few programming and say, oh, I had programming and with the new program, I have a new symptom that I didn't have before, that's an indication that you need to talk to your your neurologist. Some of the symptoms, like I said, are progressive. So over time, some people will have worsening of balance, worsening of freezing. They may not necessarily be related to programming, but it's very important to talk to the neurologist at your follow-up visit to make sure that they consider this as a possible side effect of program and see if any adjustments are needed.
Okay, so it sounds like there's a couple different ways to think about this. So on the one hand, if something is a new thing that's a very dramatic and sudden change, that may be a sign you got to talk to somebody more directly, because that shouldn't necessarily, that would be uncommon, I guess is what you'd say.
That wouldn't be uncommon. There are some times that we make great adjustments in programming. Everything is well controlled, and the patient goes home and they're taking their usual dose of medication. At 2 or 3 doses in, they have extra movements, and they call us back and say, "Oh, I had programming and I took my medications. I have extra movements." That's actually an indication that the placement was very well and the location of a stimulation is very good. So we will tell the patients to, over time, slowly decrease their medications, or we will tell them immediately, let's now dial down on the stimulation, and then let's lower the medication, and we will dial back up later once the medication is lower, so you don't have that dyskinesia. So but these are like anything that you see as a change after programming is something that you should discuss with the neurologist.
Thank you so much, Dr. Safarpour, for your time.
Mm-hmm. Yeah,
and
we're making this information available to the patients, and I hope this helps.
I'm sure it's helped me a lot, and I'm hopeful it'll help the audience as well. And yeah, thank you for your time. We'll talk again sometime soon, I hope.